But hi, everyone. My name is Sarah Eisinga, and I'm the Manager of Patient Programs, Research and Advocacy here at Lymphoma Canada. And this is a breakout session on aggressive non-Hodgkin lymphoma. And I'm pleased to welcome you, our expert speakers today, Dr. Mona Shafey, Dr. Diego Villa, and Dr. Pamela Skrabek, to answer your questions from the breakout sessions on diffuse large B-cell lymphoma, mantle cell lymphoma, and peripheral T-cell lymphoma. So this question and answer period is being recorded and will be available after the conference. And please type your questions into the question and answer box at the bottom of your screen. We'll try to answer as many questions as possible in this discussion. And I'll start with a roundtable format. So if you want to ask a specific question to the doctor, just let me know in the question that you type into the box there. So we'll start with one of the first questions. I think this is for Dr. Shafey. Which indolent growing lymphomas can often transform into diffuse large B-cell?
Well, technically all of them can. They all have different rates. Usually it's not very common though. If you take all comers with an indolent lymphoma, maybe 5 to 10% of those patients will ultimately transform. But it is something that we keep in the back of our mind when we diagnose a patient who may not be presenting typically as an indolent lymphoma. We always have that assessment or question we'd like to answer before we embark on their therapies.
Awesome. And does anyone think that there's which lymphoma subtypes are the most common to transform into diffuse large B-cell?
Well, I would say the most common indolent lymphoma, right? So the most common indolent lymphoma is follicular lymphoma. So that would be the one that we routinely would check for. But I've had patients with Waldenstrom's, I've had patients with CLL, patients with marginal zone, all comers essentially, even hairy cell, which is an extremely rare indolent non-Hodgkin's lymphoma. I've had 2 in my practice that have transformed to large cell.
Okay. So we'll move on to the next question, and maybe I'll direct this towards Dr. Villa. Are there any barriers for non-Hodgkin lymphoma patients to enroll and participate in clinical trials? If so, what are they?
Yeah, I think there are a few barriers. Every single clinical trial will have a protocol that outlines the inclusion and the exclusion criteria for a specific treatment. So you really need to look at the details of what trials you have at the time and whether that patient that you're seeing meets or doesn't meet those criteria. And just to give people a sense of what these criteria are, sometimes they're looking for fitness. Sometimes they're looking for a certain number of previous treatments that somebody has had or hasn't had. Other times, certain other conditions, such as a recent cancer or recent heart disease or a recent stroke, make people ineligible. So I think that's kind of one aspect of it. The other aspect of it is what is the treatment itself. So for example, there are treatments that are finite. There are treatments that are given for a year or 2. There are other treatments that are given on a continuous basis. And so for some people, geography is a challenge. For some people, being able to come to the hospital for the various visits involved with a clinical trial is a problem. I would say that the main barrier is availability of trials. We have trials at the academic centers, and at least, for common cancers like follicular lymphoma, we will usually have a trial or 2. But, that doesn't work if you don't live close to a center where a trial is available. That being said, I think all of us in this roundtable have trials at our centers and are obviously keen to offer them to our patients whenever there's a need to consider a change in therapy. And in fact, my own personal algorithm is, if I'm seeing someone with an indolent lymphoma and there's a treatment decision, the first break in my algorithm is, do I have a trial, yes or no?
Okay, good answer. Dr. Skrabek, I'm going to direct you a patient question that has come in on the chat. This patient says, is there a higher risk of recurrence or new cancers if the original diagnosis was stage 4? They've had R-CHOP and then reoccurrence within a year. then GDP, and a successful autologous stem cell transplant. What do you think is the possible outlook on this?
Okay, so I think there's two parts to the question. So one is there a higher chance of recurrence, and then the second is, other cancer risk. And so generally speaking, if lymphoma has recurred and requires retreatment, that usually means that risk of relapse again is higher than it is at the onset. And so that is an unfortunate fact, and sort of how high the risk is depends a bit on how long the initial remission was. Longer is better, and other characteristics of the cancer itself and how it's treated at relapse. As far as second cancers go, certain cancers, specifically blood cancers like MDS or leukemias that are related to chemotherapy itself, the number of treatments you receive will relate to that second cancer risk. Other second cancers are probably a little bit harder to tease out the correlation with treatments, but radiation is a risk factor for second cancers.
Okay, well, I hope that helps our patient that asked that question. I guess I can direct this to generally everyone and see what they comment on, because this patient, they have noticed that we haven't had a session on primary mediastinal B-cell lymphoma today. So could everybody maybe comment on some treatment options, what's like new and exciting for this lymphoma treatment? And particularly, they mentioned relapse and refractory patients.
I can start with that, if that's okay with the other panelists. So I think that primary mediastinal lymphoma is often lumped with diffuse large B-cell lymphoma. And so I think that's potentially why it hasn't been identified as its own session, but it does have unique features in terms of the genetics as well as how it presents and how it behaves. So I think that that's maybe an important consideration for down the road. Treatment options, that's a lot to go over in a short period of time. We do treat it fairly similarly to other diffuse large B-cell lymphomas. So Dr. Shafey, a lot of what she went over would be applicable. One difference that I can think of, but I'll get the others to comment as well, is that we are using immunotherapies at relapse now and that diagnosis, whereas that's not really as applicable. So what I mean by that is like pembrolizumab or nivolumab, not as applicable in other diffuse large B-cell lymphomas.
My only additional comments is that for most patients with primary mediastinal B-cell lymphoma, the prognosis is excellent, which is better than what we would expect for large cell lymphoma. And there are going to be the exceptionally rare patient who has either primary refractory disease or has relapsed after initial therapy. And like Dr. Skrabek said, there are some therapies that have been shown to be quite effective in this disease. The immunotherapies she listed, even CAR T-cell therapy is an option for some patients. So I think that we still have ways to salvage people quite well if they do in fact progress after initial treatment. The only other comment I have is the role of radiation treatment. That's changing. Many centers are using this less and less in the treatment of this disease, particularly younger patients, to avoid the long-term toxicity. And this seems to be successful as we use PET scanning imaging to help us determine how well they're doing.
Awesome. Dr. Villa, do you have any comments, or do you think those questions are answered well?
No, nothing else to add.
Okay, sounds good. I guess I'll go back to you, Dr. Villa. There is a patient question. that is wanting to learn a little bit more about indolent mantle cell lymphoma. And their question is, so do you have any patients with indolent mantle cell lymphoma? And if so, how long is the average watch and wait time?
Yes, so we do have various patients with indolent mantle cell lymphoma. So we published this, and I can put the reference in the chat. So there's a paper which is now 5 years old. And in our hands in British Columbia, we can observe somewhere between 15 to 20% of patients with mantle cell lymphoma before they need treatment. And those patients typically have the leukemic non-nodal form of mantle cell lymphoma, which I discussed at the beginning of the talk. Not everybody can be observed. And even when you observe patients with leukemic non-nodal mantle cell lymphoma, many of them progress and you have to treat them. In our study, the median time to treatment was 36 months. What that means is that by the 3-year mark, 50% of those patients who we selected for observation, their disease progressed and required treatment. But it also means that by the 3-year mark, the other 50% were well and went on with observation for a much longer period of time. And in fact, I have a few patients in my practice who have had very indolent mantle cell lymphoma and have not required treatment for 8 to 10 years. But I have to say that is a small proportion of patients.
Okay, good to know. Thank you. Let's see another one. I think I'm going to direct this one to Dr. Shafey. One patient wants you to touch upon the efficacy of EPOCH-R for double hit lymphoma, stage 4, as well as remission rates and overall survival rates.
So as I mentioned in the talk, double hit lymphoma is one of the lesser subtypes of diffuse large B-cell lymphoma, but does carry a higher risk of relapse. And so we tend to intensify treatment. Dose-adjusted EPOCH-R is a way to do that. And we feel it does improve outcomes over our standard R-CHOP treatment. So I think that even though you have stage 4 disease, the expectation is still cure with the use of dose-adjusted EPOCH-R. And in the patients who are not responding or primary refractory, those are the patients that we worry about the most. And strategies now are try to proceed with salvage treatment. And in fact, hopefully in the next year or so, we'll be able to use CAR T therapy in second line for those particular patients.
Awesome. So I'm just looking at the chat box again. I think I'm going to direct this one to Dr. Skrabek. Does lymphoma primarily in the abdomen have a worse outcome than other areas of the body?
It shouldn't. So it can be sometimes a little bit harder to get the diagnosis in patients where there's no lymph nodes that are easy to get at. But aside from the brain and maybe a couple of other organs like the kidneys, most other locations of the body have similar prognostic implications.
Okay.
Yeah, I would also add, when you say the abdomen, I think you need to distinguish something Dr. Skrabek is getting at, which is one thing is having lymph nodes involved in the abdomen, and another thing is having organs involved. And I think it's an important distinction. So we know, for example, if there's involvement of the adrenal glands or the kidneys with diffuse large B-cell lymphoma, there's a much higher risk, for example, of developing a relapse in the brain down the road. Even if it's a small amount of lymphoma in those organs, if you have many areas of involvement in the abdomen, so add liver, pancreas, bowel, et cetera, that increases not just the risk of a brain relapse, but in general, reduces the chances of the treatment being effective.
That's a good comment. Thanks for that. I think I'm going to go to the next patient question. So I guess each of one of you can touch on the subtype that you talked about for the breakout session. What are you excited about for your novel and innovative therapies in the subtype that you had a breakout session on?
Well, for large cell lymphoma, I think the biggest excitement we've had in a while has been the CAR T space, and trying to use that better and trying to avoid toxic therapies that don't work in patients who are high risk of failing that therapy. So I think that CAR T is moving into the second line. I suspect the next step will be to look at higher risk patients and consolidating with CAR T even after first line treatment. In addition to that, there are some other immunotherapies out there, antibodies called BiTE antibodies, and probably talk more about in the indolent lymphoma space, but that too is being looked at for a large cell lymphoma. So lots of ways, lots of things coming up in terms of trying to, again, improve, trying to cure this lymphoma the first time around.
Awesome.
So for peripheral T-cell lymphoma, I think that one of the things that I highlighted in the talk was that we have a randomized trial that actually shows an improvement in outcomes, specifically decreased risk of relapse and improvement in survival when brentuximab vedotin is added to the CHOP type backbone for patients who express CD30. So I think that's a major change. And in terms of other new things, I think there's a lot more being learned about the genetics of T-cell lymphoma in the last number of years than there was known in the past, and that will likely, hopefully, lead to some further improvements in treatment.
Awesome, thank you.
And I think for mantle cell lymphoma, to me, the big thing is having new drugs with different mechanisms of action than what we have had up to this point. So I think a huge breakthrough in mantle cell lymphoma was the BTK inhibitors that people are familiar with. So, I think most people are familiar with ibrutinib, acalabrutinib, zanubrutinib, and they have changed how we treat mantle cell lymphoma. But at some point, these patients do develop disease resistance. So to me, kind of the two main items here are, number one, there are new BTK inhibitors that are able to overcome that resistance. So they just bind to the BTK in different ways, and those are being developed. And I think that the community at large has a huge interest in those drugs because they're oral and they seem to be very safe, actually safer than the drugs that we have in the market right now. The other thing is a little bit like in diffuse large B-cell lymphoma, we also have CAR T-cell therapy coming for mantle cell lymphoma, and there the response rates are quite impressive. 93% of patients respond to CAR T-cell therapy, and 2/3 of those patients are actually complete responses. I mean, these kinds of results in patients with mantle cell lymphoma who have all been treated with ibrutinib, acalabrutinib is quite impressive, and we obviously that creates even more questions as to how we're going to use that in our Canadian setting. But it's certainly encouraging.
Awesome, thank you everyone for the comments. I think I'm going to direct the next question to Dr. Shafey. It's the one in the chat. So is there a difference between double hit, or can you just clarify the difference between double hit diffuse large B-cell and transformed lymphoma? This one specifically was follicular lymphoma, and then to the diffuse large B-cell.
So with double hit, in order to get that definition, you have to have the two mutations, the c-MYC mutation and then a PARP mutation, most commonly BCL2. So yes, if you have follicular lymphoma and you transform, it's more common to get that second hit to develop a double hit lymphoma. Now, in terms of outcomes, it really depends on what happened to the follicular lymphoma the first time. So I have found that if the patients were concurrently diagnosed with follicular and large cell, or if they had follicular, they were on a watch and wait, never had treatment, and then developed large cell lymphoma, their outcomes were just as good as patients with de novo double hit in terms of treatment and outcomes. The patients that have more trouble are the patients who are either being treated for follicular and they transform to large cell while on chemo, or they're relapsed. They have had follicular, they were treated, and then have relapsed with an aggressive lymphoma. So we treat those patients a lot more aggressively. These are the types of patients we would offer stem cell transplant as part of their therapy to try and improve their outcomes.
Awesome. Thank you for answering that question. Let's go to Dr. Villa for this one. So once my initial treatment is complete for mantle cell, what test should I expect as a part of my regular follow-up to monitor for relapse? Oh, you're muted.
Sorry, so this seems to be like a two-part question, right?
Yeah.
One is what are the investigations at diagnosis? And then the other part of the question is
The regular
around
follow-up.
follow-up. Okay, so in terms of staging investigations for mantle cell lymphoma, in general, we want a scan from the neck all the way to the pelvis, and a bone marrow biopsy, as well as a long list of blood work. I think that would be kind of the bare minimum that I would want to see in a patient. There are situations where a PET scan might be helpful to have a better sense of the distribution of the disease, although it's not absolutely mandatory. And every now and then, patients also have mantle cell lymphoma found on upper or lower gastrointestinal endoscopies, although obviously that is not mandatory. In general, we do not evaluate the brain unless there's a reason to do so. So somebody's having symptoms or some type of neurologic deficit that makes us think that the mantle cell lymphoma might be involved in the brain. The majority of mantle cell lymphomas are stage 3 or 4 at diagnosis. So I think we expect to find lymph nodes of some amount or involvement of the bone marrow in almost everybody. In terms of follow-up, once you finish treatment or you finish components of treatment, then you have to reevaluate the mantle cell lymphoma to see how people are responding. So again, at the bare minimum, I want to have a CT scan to see what happens to those lymph nodes. And sometimes you repeat a bone marrow biopsy, for example, if there was heavy involvement, and you're going to go for a transplant. But I think that's very person to person. In terms of follow-up, if you have finished your treatment for mantle cell lymphoma, then the follow-up is largely kind of low-tech physical exams. How are you doing? Visits in the clinic with some blood work. There is no rule as to when you're supposed to do imaging, and there are no guidelines that say you have to do scans every 3, 6, 9, 12 months. I mean, this is really driven by how a person is doing, by the depth of the response that they had to their previous treatment. And so you kind of tailor it depending on how people are doing.
Okay, well, thank you for that answer. I forget who had this lymphoma subtype, but anyways, does having had Epstein-Barr virus automatically mean that this person will get lymphoma?
No, that means everybody with mono would have gotten some kind of lymphoma in the future. Nearly everybody has had mono. So thankfully, no.
Okay, that's good. I guess I'll direct one to Dr. Skrabek. Someone has just completed their chemotherapy regimen about a month ago and still feels really fatigued. How long do you think that the fatigue is going to last for?
That's a good question. It is quite variable. For some people, they will find that they never feel quite the same again in terms of like exercise tolerance or kind of energy reserves type thing. But hopefully most people can go close to their pre-treatment level of energy. And I think, you know, the time course for that is usually longer than 1 month. So it's usually more like 3 to 6 months, but other medical issues, as well as things like anemia, medications, etc., can play a role in that as well.
Yeah, I agree with Dr. Skrabek. You know, fatigue is a multi-dimensional kind of experience. So it's not just that the leftovers from the chemicals make you tired. I think there's more to it. So just to add a little bit to that, you know, we know that patients who go through chemotherapy, especially regimens with steroids, like, you know, CHOP, GDP, ABBD even though it doesn't have steroids, but there are steroids in the pre-medications, there is a change in the metabolic composition or in the muscle to fat composition of a person's body, and that directly is related to fatigue. So that's one component. So how much physical activity you were doing prior to chemotherapy versus after chemotherapy will feed into how much fatigue you experience. The other component is something called chemobrain. And what that is that, the chemicals do make it to the brain and do cause some brain damage. And so some people say they have fatigue when what they really have is some amount of cognitive damage from the chemotherapy. They can't remember things, those kinds of things. And again, that's directly related to how fit you were during your chemotherapy, whether you maintained mental fitness during your chemotherapy, so whether you worked or you didn't, and also age. So it's just various components to fatigue. In general, I say to patients that whatever long your treatment duration was is whatever long you can expect at the minimum for your body to recover, but you need to be a proactive partner in your recovery. So sitting on the couch waiting for the fatigue to go away will not work.
Thank you for those comments. I think they're really good. Let's just go with one last patient question, last one that was typed in the chat. Anyone who can answer this. So it's in a PET scan, does SUV value in lymph nodes, which is much higher than the SUV value of the liver, indicate reason for concern? Then why might it not?
Well, that's how we use PET scans. So when we talk about patients and end of therapy scans, we measure the metabolic activity relative to the liver. So obviously in a patient with known lymphoma, if they were to have activity that's higher than the liver and residual lymph nodes, then this would be concerning for us for persistent disease. The issue that comes up are for patients who achieve a negative PET and then something new comes up that's not necessarily in the lymph nodes, or maybe in a lymph node that's not enlarged. And those are harder to distinguish. So, in the case of a COVID vaccine, sometimes the lymph node gets active. That happened quite a bit over the last year and a half. And so we would ask about vaccinations. And painful lymph node in the left armpit, for example, would have been classic for that. And it would have shown up hot or hypermetabolic on a PET scan. I've diagnosed other diseases, a patient with lung disease who had sarcoidosis. And the only way I could distinguish lymphoma from the sarcoid was to do a biopsy. So sometimes that happens. When we're not sure that this is lymphoma, then the best way is to get a tissue diagnosis.
Yeah, I agree with that. I would add that PET scans are very reliable when they're negative, so there's no areas with uptake more than the liver, but have to be interpreted with expertise when they're positive, because of the possibilities that it could be lymphoma or other things, which is what we'd call a false positive.
Awesome. Well, thank you everyone for answering your questions today. We really appreciate it. And everyone, please do stay tuned for the closing remarks happening in a few minutes. Thank you, everyone.